Awesome. Well, thanks for joining for this week's DDU teaching. We're going to go through respiratory failure. These are the questions. Umi, is it your turn to go first, do you think?
Yeah. So for the first question, I describe it by just dividing it into three different categories. The first one, most importantly, I want to do rapid focus assessment of the right heart. And things that I'll be looking for will be the RV size and function. Sam, can I just clarify here? Because the subsequent question has got more detail, and this is
Yeah,
just 3 marks. So that's why I've just left it as generic. Otherwise, there's a lot of repetition.
exactly right. So 3 marks, so it's out of 15, so it's probably about 4 minutes worth of writing. So I don't think there's a right or wrong answer to how you do it, as long as it's done, in a it's done in the it's done in a systematic manner.
And then the next one will be looking for septal flattening or the D-shaped septum, the coronal sign, and the TR velocity or any signs of RV pressure overload, bearing in mind that this will be underestimated if there's a RV dysfunction. Next one is I want to assess the LV function, looking for alternative forces of shock in this instance, in particular looking at the regional wall motion abnormality from ischemic event, and also assessing the LV filling status. And finally, exclude any other reversible causes of hemodynamic instability like myocardial fusion or tamponade, any significant valvular pathologies, and also use the echo to just estimate the volume status, looking at the chamber size and IBC assessment. The priority in this instance is really to rapidly identify acute pulmonary or massive PE because there's the new right heart strain on ECG with worsening hypoxemia and shock state.
Cool. So you had the first thing you mentioned then was the RV failure. So you did it in systematic order. So the LV was last with the regional wall motion and the tamponade, and first was RV failure, worried about PE and ARDS stuff. Nice. Did anyone else do it in a different manner?
And I included signs for pneumothorax as well and dynamic hyperinflation.
Very nice. Yeah, very nice. See, because I did it slightly differently because I'd have done it from a pathological point of view. So I'd have talked about the pathologies that I was worried about first. I'd kind of done it in a similar manner though. I'd have said it was, because it's on the morning ward round, he's hemodynamically unstable with rising NORADs. So that would include for me wanting to make sure we hadn't blown out the RV, and that would either be us with mechanical ventilation or by PE. Could be the disease process itself. Could be a pneumothorax again because of us with the mechanical ventilation or lines or whatever. And then also RV dilation with systolic anterior motion. That is unstable with rising NORAD requirements, sort of tells you that there's like an acute process going in there. I
Yep.
think you'd have passed the question most certainly. I think there would just be a little bit of there just to try and get that nod of the instability of it. But I think you mentioned all the pathology in there. But it's just the idea about the question I particularly put in there was like prioritizing the most clinically urgent, and that's where it could help you. So um, yeah, nice. Rosie, would you like to have a go at number B?
Yeah, sure. So you identify significant RV dysfunction, echo features of acute cor pulmonale. So just and management. So just expanded on part A really. So starting with echo features of right heart dysfunction. So 2D, so dilated right atrium and right ventricle bigger than the left side. Septum, atrial septum and ventricular septum shift to the left. D-shaped LV, apex forming RV, reduced RV systolic function. So visually, and then parameters like FAC less than 35, TAPSE less than 17, et cetera. We all know them, I won't go on. IVC diameter and estimation of RAP. And then potentially also looking for signs of embolus in veins, intracardiac and the pulmonary arteries, because this could be a PE. And then color Doppler, looking for TR and PR, which might be severe or unimpressive, depending on the pressure difference between the chambers and the degree of adaptation. And a PFO opening and right to left shunts, pulse wave Doppler, RVOT, VTI, notching, acceleration time less than 90, hepatic vein systolic flattening or reversal, and then also a Vexus, which might be consistent with backward congestion, continuous wave Doppler, PR jet profile, peak velocity to estimate PASP, and then RV free wall longitudinal strain less than 20-25%. Left heart features, looking for post-capillary pulmonary hypertension component and raised LAP due to fluid overload and LV impingement by the RV. In acute cor pulmonale, we expect a hyperdynamic LV with possible mid-LV or LVOT obstruction, signs of raised LAP, including a mitral E to A ratio greater than 0.8 to 1, reduced deceleration time less than 160, reduced mitral tissue Doppler, lateral E prime less than 8, E to E prime ratio greater than 14, and systolic to diastolic ratio less than 1. How it would guide management. So depending on what pathology is found, but with confirmation of acute cor pulmonale, I would be considering a CTPA in this instance, or even empiric anticoagulation if the patient is too unstable for CTPA. If PE was thought likely, a limb venous ultrasound might help in this instance. Fluid removal with diuresis or dialysis, lung protective ventilation, making sure vital pressure less than 30, tidal volume less than 6 mils per kilo. PEEP titration, lung ultrasound might help here. Improve oxygenation, reduce CO2, improve acidosis, dialysis might help here. Consider inodilators and lusitropy like milrinone, levosimendan. Add vasopressin to spare noradrenaline. If significant pleural effusion or pneumothorax, drain it. Repeat assessment with transthoracic or TOE, especially after management, to look for improvement. If not improving, consider pro-positioning, swan insertion, and inhaled or systemic pulmonary vasodilators if left atrial pressure is not significantly raised, and consideration of VV or VA ECMO.
Really nice. What an answer. Incredible. Do you reckon you've done that in about 8 minutes? I think you could have done that in about 8 minutes.
Yeah, I think I always tend to go over a bit. In terms of
a really nice structure there. I mean, I love the structure's excellent. Where you're going for echocardiographic features to confirm acute cor pulmonale, and you did the 2D pulse wave, 2D color pulse wave Doppler, continuous wave Doppler, and then you added in. I love the bit about Vexus. There was a bit about clinical examination in there, which I think is a really nice, combining echo and clinical stuff. This is very much clinical exam. In terms of how it altered your management, again, I don't think you should stress too much about the everything you said is correct, and I think we've worked together so long. I think your management is excellent. I think it would, in this exam, that no one's going to jump up and down if you say milrinone versus adrenaline or whatever.
Okay.
I think as long as there's a structure to it, and it sounds like you're being sensible and not giving your patient 25 centimeters of water of PEEP and no catecholamines and loads of fluids, then I think you're okay. Yeah, really nice. I don't have much to add to that. It was beautifully done. Well done. Raj, do you want to go number C for us?
Yes, Sam, I got a question here. I'm confused because I understand it's a clinical exam, but if the question is focused on echo, I was thinking how much should I focus on echo and how much should I focus on clinical things?
Yeah, so I mean it's an echo exam. I think oh sorry, go for it. Give me an example.
So for example, I was saying I'll do an echo after starting inotropes. What's the change in the FAC and TAPC and S prime? And then I'll be looking at the pulmonary vascular resistance. How is it affecting my my septal flattening? And then I'll be looking for, is there any other thing like a dynamic hyperinflation optimizing? And then is it putting back to the echo findings? Or should I do that way, or I'll be just, because I haven't. But what Rosie said, I haven't done any of those things. I simply said inotropes. I didn't discuss much in detail. I didn't go for a VV ECMO or a VA ECMO as well.
And that's what I mean. I don't think that's not the pass or fail of this. I mean, I think what we're trying to get from these kind of questions is that you know how to identify the pathology. So you know what you're looking for with acute cor pulmonale. And so that's, RV dysfunction, RV dilation, echo signs of congestion mixed in with clinical signs.
Yeah, sure.
And and to be honest, you probably don't need to be too specific at that. We kind of imagine that you know what those are.
Okay.
Then in terms of linking that with management, I think probably all you've got to do is with that, you've got to be saying that you're avoiding fluids.
Yeah.
I don't think we care if you're writing about dialysis, diuresis. We just want to know that you are avoiding fluids. You're avoiding, afterload reduction mechanisms.
Yeah.
So I think that's important. Hey, Patrick. And so does that answer your question? So I mean, I think
I got it. Yeah.
So I don't think there's, and if you wanted to take it instead of as Rosie did it, giving you all the echo features, and then she's describing her management and how it, each little bit of that would go through. And I think Rosie, you went through fluids, afterload, what happens if they fail those, need for repeated exams. If you were to do that in a different way and start off with, say you did it on preload, contractility, and afterload, and what the features are of those, that's also fine. I think what we'd be looking for would be, how would I write it if I was going to write like an examiner's note for everyone? What would I say? It'd be something along the lines of, appreciation. This is a cardiorespiratory interaction. Just listing off features of RV failure is not sufficient for a diagnosis of acute cor pulmonale. There's got to be some form of integration of some form of discussion on congestion, some form of integration of clinical features, and some sensible suggestions for reducing congestion and reducing afterload. Be along those kind of lines. So, the examiner's going to get a vibe about whether you know what you're talking about or not. And I hope that answers the question.
Yeah, I got it. Thank you.
No problem.
Sure. The next one is so 6 days later the patient is improved.
Sorry, just because Patrick's just joined. Patrick, we're going through question 1. I don't know, first time here at Fight Club, so I know I don't hope you got the I hope you got the questions that I sent.
Yeah, I do. I've had a look at them. Yeah, mate.
Brilliant. We're just on question C. I hope you don't mind. Have you got any questions maybe on A or B, or do you want me to repeat anything?
No, that's fine. Sorry, I had technical difficulties with Zoom. Sorry.
You're totally fine. I think I had you coming on from Teams or something somehow.
Yeah.
Just anyway.
Yeah.
Sorry if I messed up the invitation somehow. It's always on Zoom. I just find it easier.
Yeah, cool.
Well, if you're okay, maybe we'll just plow ahead and just Raj, we can go through question C for us.
Sure. So 6 days later, the patient is improved, remains on a PEEP of 6 and 35% oxygen, PF ratio 280. So the role of echocardiography in weaning from mechanical ventilation in this patient. So I'm not sure I get the road for 6 marks. So I look for mainly in the context of readiness for weaning and looking for the parameters that will help me about the weaning success probability. So first is I look for further optimizing the reversible features in terms of preload. So whether the patient still has signs of fluid overload, and following the trend of the vexes, as well as whether they need for diuresis. And another reversible thing, like in this patient, whether the patient has got a moderate to severe pleural effusion, that can help in weaning as well. To do this, again, in terms of preload, I'll be looking at the IVC and hepatic vein size, the Doppler. I'll be looking at the Doppler trend as well. Is there a reversibility, how the grade of vexus is improving? Then I'll be focusing on RV and LV contractility optimization, whether this patient needs any bridging inotropes to wean this patient before extubation. And then the main focus will be on, especially in this patient, will be focusing on diastology. I look at the E velocity, the decel time, the E prime, mainly the E to E prime ratio, as well as the EA ratio I'll be looking at. So before this, and also, sorry, one more parameter I'll be doing is a VTA assessment. So I'll take all these parameters at this particular set of the ventilator settings, and then I'll try to wean the patient to suitable for a 0/0, and then I'll redo the settings again. So if there is no significant difference in these parameters, I'll be looking forward towards a successful weaning and extubation in this patient.
What about spontaneous breathing trials?
Yeah.
Did you go through the spontaneous breathing trial completely there? Did I miss it?
Yeah, that's why I said, like, what I said is to assess the weaning tolerance and the possibility of success, I'll be comparing the parameters, E velocity, diesel time, E prime, E ratio, the mitral inflow, as well as a VTI
Yeah.
before and after the reducing these settings like pressure support to 0. Yeah.
Beautiful. Sorry, I missed that. Excuse me. Sorry, I zoned out, but excuse me. Yeah, that's really lovely. So, nice. What about other things? I guess maybe solid pass. I think you're mentioning all the right stuff. You're worried about left atrial pressure in particular with that. You mentioned about RV function and LV function. I think again, if I had to write a markers grid from that, I'd be talking about the cardiorespiratory, an understanding of the physiology there. And again, I think failure for weaning is not just echocardiographic. It's also going to be what's on the lungs. And so I think you mentioned the pleural effusion. I'd have thought of talking about diaphragm. It does specifically only mention echocardiography here. So I think just focusing on the echo is fine. But if I had to write that question again, if it's, for example, it's got something about lung in there, don't forget about diaphragm function that you can assess with ultrasound, obviously. You mentioned pleural effusions, B lines in there, but I agree, it's only 6 marks. So focus on the echo. And just a little bit of a nod towards physiology. Did I miss that? This idea about as you drop the PEEP or extubate in, that idea of increasing preload, increasing LV afterload, and maybe reducing RV afterload. I think did you mention those? Did I miss? Had you mentioned that in there?
No, I simply said I'll optimize the preload, but I didn't tell about the
Yeah, I think it's a clear pass. I think I'm probably just picking at straws here, and it was a really nice structure to it. But again, just various ways of trying to do it. You've done it via similar to Umi in the first question. You've done it with sort of an echocardiographic, looking at RV, LV, left atrial pressure, and that's totally fine. And then you mentioned about how those parameters might change with a spontaneous breathing trial. I think just to keep it clear for the examiner, headings in there would have been nice. I'm sure you've probably done something like that. And then the alternative way is you do it again from about, the physiological things. So what happens as this patient is weaned? He's improving. He's looking pretty good, but he's still on a really okay level of PEEP. He's low oxygen. He's got a good PF ratio, but it's not amazing. So we've got to be trying to. These are the kind of patients to do PEEP trials on, and then you could use that preload afterload concept just to make it clear for the examiner. But I think it'd have been a solid pass, Raj. Nice one. Let's move on to the second one. Hey, Patrick, can you remind me again? You're sitting this year, aren't you, in August?
No, I won't be ready. I'm still catching up on all my case studies and that, so I'm a bit early.
I might stick with some of the guys who are going to be going for August then, if that's okay. And unless you would like to have a crack at the first one, do you want to have a go? First time at Fight Club? You don't have to.
I mean, I can have a go and you can
Cool.
add.
Right.
Yeah.
Go for it. Well, let's take me on the first one then. Sorry, the part A of question 2. So, 72-year-old woman admitted to the ICU with fever, acute dyspnea, and hypoxia. She has a past medical history of heart failure with preserved ejection fraction. That well-known, most useless diagnosis known to mankind. Tell me about compare and contrast lung ultrasound features of cardiogenic versus ARDS, cardiogenic pulmonary edema versus ARDS.
Yep. Okay. So I just did a motherhood statement saying lung ultrasound can help discriminate ARDS from APO by looking at the features of the pleura, the subpleural space, and distribution of B lines. So then I just did a table with APO and ARDS as our columns. The first row I did pleura. So I said under APO, I said it's smooth, thin, and mobile pleural line. Whereas with ARDS, it can be thickened with reduced motion. And then I went on to B line. So in APO, usually it's diffuse and bilateral, whereas ARDS can be unilateral or even patchy. Then I did the subpleural space. In APO, I said that's usually normal. And in ARDS, there can be some subpleural consolidation or shred sign is also common. And then I did a fusion. So I said for APO, fusions are common and they're usually bilateral and simple in nature, whereas ARDS, the effusions are usually uncommon, but if they're there, they can be unilateral, and there may be septations and loculations depending on the cause of the ARDS. So that's how I differentiated the signs of edema, pulmonary edema, and ARDS.
Did you tell me about the parenchyma? Sorry, what did you say about the parenchyma?
I just talked about B lines. Oh, I suppose I could have mentioned I said subpleural consolidation, but I could have put something in there about like, consolidation, hepatization.
Yeah,
Yeah.
nice. Because I think you've got a lot. I mean, for me, I think a big part of ARDS is also lines of collapsing. That's where the baby lung stuff comes from.
Yeah.
And so talking about atelectasis with the ARDS. And again, just this idea of reading the question, right? So we got compare and contrast. You gave me a lot of contrasting things. What are the same between them?
The same things. I suppose B lines are common to both, like interstitial syndrome. So they're going to be common, but there's going to be probably distribution difference in those B lines.
Yeah, beautiful, beautiful. Exactly right. So I think that'd be the big comparison for me would be there are B lines in both of them, but in cardiogenic pulmonary edema, it's going to be more dependent. And unless it's a ruptured PAP muscle, then it's unilateral.
Yeah.
With eccentric MR versus ARDS, it's going to be more of a sort of homogeneous pattern. Yeah, very nice. Anyone else do it differently?
Yeah, like yes, like I was like I classified into the pleura, B lines, atelectasis, and consolidation.
Nice. So you did again pathological rather than ultrasound other than the domain on the ultrasound. Yeah, cool. And did you do comparison as well as
Yeah,
contrasting?
yeah. Made it
Yeah,
to
great
tape.
job.
Made it
Nice
to
job,
tape.
nice. Good, cool. Umi, back to you. So you got the 10 marks, so that's going to be at least you got 15 minutes, so you got 10 minutes to answer that question. So tell me about the how you can use echo and lung ultrasound to help with setting PEEP.
My motherhood statement is the lung ultrasound will help us to identify recruitable lung and overdistension, while the echo will help us to evaluate the hemodynamics tolerance. And then in terms of assessing the lung recruitability and monitoring the response to PEEP on the lung ultrasound, when there's the dependent consolidation or the Kralins B lines will suggest that there's some degree of recruitable lung, and this can be basically confirmed by doing PEEP titration. If with increment of the PEEP, the consolidation and the number of B lines they are reducing, and or even changing from the B line pattern to A lines, that indicates that there's improvement of aeration and there's alveolar recruitment. And if it's like not changing or it's persistent, then it suggests that that's poor recruitability of the lung. And when it comes to detecting the overdistension, excessive A lines in the non-dependent lung or reduced sliding suggests that there's overdistension. In terms of the
excessive A lines. So, do you say excessive A lines or B lines?
A lines.
How do you get excessive A lines?
No, it can't be. I think maybe reduced sliding suggests overdistension.
Reduced sliding's just overdistension. Yeah, I wonder about that. So anyway, we'll come back to that. Keep going.
And then now I'm moving to the echo for the hemodynamics tolerance assessment. So assessing the RV function, high PEEP may increase the RV afterload. So looking for signs of RV dilatation, the D-shaped septal flattening, and reduced RV function. Then assessing the cardiac output on the echo by measuring the LVOT, BTI, and / the stroke volume before and after changes in the PEEP. If there's falling of the BTI, then that suggests that there's reduced cardiac output from the excessive PEEP. And finally, it's about integrating both the lung ultrasound and the hemodynamic response or tolerance from the echo to choose the optimal PEEP. So the optimal PEEP will be where there is the maximal lung recruitment on the lung ultrasound with preserved RV function and cardiac output on the echo.
Nice. Very nice. Take me back to the A lines. You said excessive A lines, because I thought A lines are only going to happen because if you've got normal lung, you've got that sound wave that's just basically reflecting from the pleura to the skin probe interface and then sort of back down, and that's how you get. So they're all exactly well spaced. That's a sign of normal lung. So what did you mean by excessive A lines? I
think it's presence of A line in the non-dependent lung.
Got it.
Sliding.
Got it. Okay.
Is that accurate though, or that's still not right? Like when there's reduced sliding and you've got A lines?
Yeah, and again, I'd say just a couple of things I pricked my ear. So I think even if you've got over distension of a lung, you're still going to get lung sliding signs because you've got some form of movement of the chest, I think, unless you're absolutely at capacity. Uh, I think absence of lung sliding is signs of pneumothoraces
Yep.
or a right, main stem intubation if you're looking on the left, or complete blockage or it's significant atelectasis. I think you're still going to see a little bit of lung sliding, even if you're at maximum distension, because you're still going to be getting some movement of the alveoli against each other, even if they are massively distended.
Yep.
I think the other part I was going to say is this idea of that, U shape on the PEEP, that if you've
Yep.
got too low, it's gonna be causing harms. And if it's too high, it's going to be causing too much harm. And again, that kind of nods to idea that this is, fundamentally a cardiorespiratory problem. And I guess I love the way that you were then talking about findings that you're going to have and what that would be linked to in terms of cardiac output and things. And then it was just the one thought that you said, if the LVOT, VTI and the stroke volume goes down, I think you said that it might be a sign of over distension. And it could also be a sign of maybe too little PEEP as well, in terms of atelectasis. And I think that's where just the nuances come out. I love the focus again on cardiac output. I thought that was very reasonable and making sure you're not avoiding blowing out the RV. So not bad at all. Um,
Can I just find out from other people what kind of heading they've like used for this question?
Nice question.
Yeah, I did it a little bit differently because I thought that it was quite a broad question. So I actually started like my number one part was actually just like diagnosing what the problem is, which I don't know, maybe is out of bounds of the question. So my first part was just identify cause of respiratory failure, which may be multifactorial given the stem. So it could be cardiogenic pulmonary edema, pneumonia, ARDS, or PE. Uh, and so my first part was like actually initial diagnosis with lung ultrasound, with echo, and then listing the abnormalities that we'd see with those differentials. And then I had set initial peak based on the diagnosis because it'll be different. I thought whether it was a cardiogenic pulmonary edema or AR, versus focal or diffuse ARDS. And then the last part was peak titration. Full disclosure, I didn't do this to the time because I actually didn't really know enough about lung ultrasound. So I did look up some resources. So I actually had a bit in the peak titration looking at diaphragm ultrasound as well, because that was mentioned in quite a bit of studies. So the diaphragm ultrasound, so PEEP is known to negatively impact diaphragm function. Goal is to minimize diaphragm injury. So signs to look for is normal muscle thickness and expiration, optimal contractility, so thickening fraction between 34% and normal excursion, which greater than 2 centimeters is normal. And then the lung ultrasound and the echo stuff was the same as UMI. And then there was this thing that I was reading about, which is called the lung ultrasound score, or LUS, which is mentioned in some stuff around more like ED echo. I don't know how relevant it is to us. Have you heard of this? Do you ever use this, Sam?
I've heard of it, don't use it.
Right.
I mean, maybe we sort of do use it.
I guess we don't
maybe
we
have a
don't formally
score.
have it. Yeah, we don't have this, but we are looking at. So it basically was like 0 if it's A line predominant, a score of 1 is B lines less than 50% of the screen, a score of 2 if it's greater than 50% of the screen, and then 3 if there's consolidation air broken ground. So just the level of severity of like consolidation atelectasis.
Yeah, it was the one thing I sort of written down there about using lung for PEEP titration is that idea that if you don't have enough aeration, you're going to see atelectasis. As you then increase the PEEP, you will get B-line patterns coming because of the fluid and maybe inflammation. And then as you increase the PEEP more, you will get maybe less B-lines. And then when you're over descending it a little bit, you could get A-line patterns. And I think Umi you were discussing that a little bit in there. But I didn't give it a scoring system. What do you say about the diaphragm?
Me? Oh, I just said so the goal is to essentially so PEEP is always going to have negative impact on the diaphragm, but the goal is to sort of minimize diaphragm injury and avoid atrophy. And then there was some part in the literature about if there's after like an increase in PEEP, if there is increased excursion in the dorsal areas of the sort of like the back at the diaphragm, then that might indicate some successful lung movement. I don't know if you.
That sounds like bullshit to me. I mean, I don't know how much lung ultrasound you've done with diaphragm. It's quite challenging, I'll be honest, to try and pick up this dorsal. But I'd love to see the paper in that. Maybe they can persuade me. Because the reason I was asking is that what methods do you know about assessing diaphragm function?
Not much. Do you mean like esophageal?
No. So with ultrasound, sorry, I've said
just with ultrasound.
With ultrasound. So we got two ways of doing it. What are those?
Okay.
Anyone can answer.
One is the excursion of the diaphragm, looking at the slope.
Yep.
And second is the thickness of the diaphragm with the contraction.
Fantastic. So one's done with an echo probe and one's done with a linear probe, right?
Okay.
And so if you're doing, and I'm sorry if we didn't go through this enough when you were here doing the echo fellowship, so the diaphragm one, it's always easier on the right to do it than the left. I think that'd be the key thing to talk about. So the left is a lot harder to look at diaphragm movement, but not impossible. You're using the spleen or the liver as the echogenic window. And then you can look at excursion, just like Raj was saying. And excursion, the bigger the excursion, the greater the effort and the greater the function of the diaphragm. The problem is if you're mechanically ventilated, that is not a measure of diaphragm function, okay? Because that's a measure more of almost like recruitability, I guess. Can it move a bit further? Which is, I think, what they're trying to get at in that study, saying that the more it moves, the more aerated you've got your lung. But again, I think trying to set PEEP based on that has got multiple problems because of ARDS and the baby lung and the risk of overdistension for me, which is why I wasn't 100% sure that looking at diaphragm excursion was the way to assess that, if that makes sense. So the other way that is looked at more in terms of maybe more in weaning studies is the thickening fraction. So that's you're going to do it in what's known as the zone of apposition, which is up around, in the anterior axillary line, about level, I don't know, 6 to 8 on the ribs. And you find you got two ribs, you got the diaphragm just underneath there. So you're sort of cutting across two ribs. You have the shadows that come down on the side, and then you've got a pleural line and then the diaphragm sitting underneath that. Sorry, other way out. Diaphragm sitting on top of the pleural line. And what you'll see is the better the function, the more it thickens. But if you're fully mandatory ventilated, it doesn't thicken, right? Because it's all about respiratory effort. So it's this idea that it's really hard to measure diaphragm function when you're mandatory ventilated, and it's hard to do it when you're on a bit of PEEP and pressure support. So that's why I think it's tricky to mention it, but certainly if it's more of an idea for weaning patients, I think, trying to see what happens as you turn down the PEEP. So that might be where you could bring that in. Okay. Nicely done. Let's do some cases. Can you guys see that okay? Cool. Where are we back to? Are we back to Umi? Okay. Case 1.
63 viral pneumonitis or it's short of breath, febrile, on an IV, SATs is okay, tachypneic, background of ischemic heart disease and hypertension. So this person is probably like really difficult to image with the current context. So there's a subcostal view, and also the other one, I'm not sure, is it just like a parasternal that's really low? I'm not really sure.
And why is that?
The acquisition. So basically on this image, we can see that the RV and LV function are both reasonable. I can't really comment much on anything else beyond that. The main particular focus will be the RV, and the RV functions looks normal in this like one image that I've got. And then this apical tree, I'm not really sure what's the right top pen. Is it a plex that's really low, or is it
Yeah,
a
very nice.
apical tree chamber?
Yeah, and either one would be fine, to be honest. And as you can imagine, these guys can sometimes difficult to scan when they're hyperexpanded, and yeah, low parasternal is what this one was. But it's a way of having a look at the LV any way you can. Another take a normal or mildly impaired LV. RV is normal in size and function. Very nice. What else can you see if you're thinking about patients with ARDS? Obviously, you told me in your previous question you were worried about RV size and function.
Postal view, you can see some B lines there.
Yeah, nice, excellent, good job. You can see some B lines coming in there. I was also thinking about the atria. We don't have an overloaded right ventricle because that interatrial septum is pushed towards the right. So if anything is suggestive that the right atrial pressure the left atrial pressure might not be raised, but it's higher than the right atrial pressure. And all that's telling us is that we don't have significantly elevated RAP. Cool. Estimate the left atrial pressure for me.
The EA ratio is like 0.8. The D cell time is 20.
D cell is 200 and anywhere from 260 to 320.
And then left atrial volume size, it's sort of mildly enlarged if it's being indexed. The E to E prime is like borderline of the cutoff. I use the cutoff of 14, but it really varies on the image. And then the TRV max, the RV function in this context, it was normal. So the TRV max is less than 2.8. And in terms of the EA, it's A predominant. So I will say that it's with the normal LV systolic function, a predominant wave, I will say that the left atrial, there's no signs of raised left atrial pressure.
I mean, I'll just be cautious of this TR velocity. I'm guessing if you did that to my lungs, you're going to get some form of TR being raised in me, but my left atrial pressure might be normal. The TR it's just, I don't think we should be including that in our assessment of left atrial pressure. So maybe it's a bit cheeky to put it in, but this is the kind of thing where I'd be ignoring it, because having some form of pre-capillary pulmonary hypertension with an X-ray that looks like that is probably quite normal, particularly when you're a bit hypoxic. I haven't told you about the acid status or the PCO2, but this patient is hypoxic for what they're on, with NIV and FI2 0.4. I think our saturations will be closer to 100, I hope. But so we're a bit hypoxic, a bit hypercarbic, maybe a bit acidotic. That's all going to raise up your TRV max. We can't really use that in left atrial pressure estimation. And so if you've got a bit of a mildly dilated left atrium, we've got some impaired relaxation in there, an E to E prime, there's borderline, an E to A ratio of 0.8. I'd have taken normal left atrial pressure. It can be mild diastolic dysfunction, but I still think we've got normal left atrial pressure. This does not look massively elevated. I'd be putting that with a massive caveat that echoes not massively sensitive in a single standpoint. I'd be taking all of this with a pinch of salt. I don't think he's got massively elevated left atrial pressure. I don't think there's a major post-capillary pulmonary hypertension process going on here. Whether this gentleman is fluid intolerant or not, need a bit more information, but I don't think the left atrial pressure is super raised. And I'm mainly saying that because of my E to A ratio. But with a mildly dilated left atrium, impaired relaxation, there might be a bit of a chronic component to this, and that might mean this patient could be fluid intolerant. So just be judicious if you're even considering fluids. Yeah.
Yep.
So I guess it's that kind of, you can put some of that clinical nuance to your answers. The examiners, it's all about sort of putting the echo and the clinical stuff together. Cool. Keep going.
Is this from the same time?
Same patient. So the same patient, I'm just taking you through 4 slides of the same patient findings. And then as I'm sure you're going to guess something's going to get worse.
So the image quality of the apical fold chamber is really suboptimal. But again, like, the LV function is still looking normal in that. And the subcostal, the RV function is normal. The fractional area change. I need to look at the 2D quality really to really interpret whether I can take the fractional area change. Just numerically, the number 35% is normal. And a TAPSE, that's also normal. The TAPSE is sort of fitting with my eyeballing. The fractional area change that's normal is also fitting with my overall eyeballing assessment.
Very nice. Very nice.
Can you read the pulmonary acceleration time?
Pulmonary acceleration time is I've got 2 measurements. One says 120 and the other one says 140.
So the pulmonary acceleration time, just based on the measurement, it's normalish, like the cutoff that I use for abnormal is less than 1T, but I'll be a bit cautious about the image quality or the way the measurement's done, because it needs to be optimized further, because it's very prone to error in terms of the measurements. So I'll be quite cautious with taking the measurement that's done there. What's the other image? I can't really see what's the 2D. Is it like a really TR?
2D was just I think that's parasternal long axis just tilting up. And then the one down in the bottom right is a parasternal short axis looking through the TR.
TR Vmax. So we've already discussed a little bit about this TR. The TR envelope is not complete, but it's sort of, the peak is about where it's measured 2.6. I think in this instance, I'll be a bit cautious with the number that's been like all put up, because I think there's a lot of caveat to it. The pulmonary acceleration time, the profile, there's no pre-capillary or mid-systolic notching in the profile. I'll be relying on the profile more rather than the number. The image needs to optimize further for a more reliable number. Just numerically, the numbers like not concerning. So
Nice.
the degree of pulmonary hypertension, I need to look at the IVC and the hepatic vein to come up with the pulmonary.
So if you had to put that all together, what do these features show you? So you've got someone who's got a chest X-ray that looks like that, who's hypoxic on non-invasive ventilation and tachypneic. Put it all together for me. What do you think?
Yeah. So this person at this point of time has got preserved RV function, but he's still at risk, and the serial assessment will be more important rather than the static single off parameters that's been done for him.
Yeah, good. And these kind of things, I think we love putting in the exam because they're all kind of okay, right? And what these findings did for me when we were looking after this patient was put us at ease a little bit, because it meant that we didn't have significant increased RV afterload at this stage. The heart was coping with that degree of insult pretty well. And I think that's what we're expecting the exam candidates to come out with, saying they almost feel reassured by some of this stuff. We're not always just going to show you horrific pathology, because I think that means that you're just tuned to, expecting that. You've also got to be able to recognize normal. And so a good candidate, I think, is also going to be able to put the clinical stuff together, because this patient is super sick, at risk of deterioration. I think this is the last bit I'd love to sort of just try and get you to go just that little bit further, because I'm showing you all of these things because in this patient, I'd be also saying that with an X-ray like that, this guy's about a sneeze away from being intubated. And intubation is going to be tough for this guy. If we have to do it, we're going to do it. We can argue about the idea of NIV in pneumonias and the NIV part of this, but I think it's trying to sort of balance that idea of, is this patient about to go into pulmonary edema? Is this patient about to need intubation from a cardiac point of view? I would have thought a good candidate is going to look through all of this and say that this patient is probably going to need to be intubated because, of their severity of illness. If we do intubate them, we are not, this patient is not should not be for intubation because the RV is not blown out. The RV is okay. We don't have signs of increased left atrial pressure, but you've got to be really careful with giving fluid to this guy. And we've got no signs of major pre-capillary pulmonary hypertension. So we've got some room to move, and clinical examination would be key to further management of this patient. All right, Raj, let's move over to you. So, Raj, this is the deterioration that happened on day 3, so worsening chest X-ray findings. And he is intubated. And after intubation, we've got horrible hemodynamic deterioration, metabolic and respiratory acidosis occur, acute kidney injury, lots of catecholamines required, and lots of support from the ventilator. Tell me what's going on.
You're on mute, Raj.
Sorry. So there's a personal short axis. RV appears dilated. The left ventricular cavity appears small, and there is a septal flattening. I have to slow down and see exactly in which phase is it. It looks to me definitely in the systolic phase. Yeah, there's a diastolic phase as well. I have to see. Yeah, it looks like predominantly in the systolic, but there is as well in the diastolic as well. So there is, I would say, like, but there's pressure overload plus minus volume overload to the RV as well.
Cool.
The TAPC is 14 millimeters. It is less than normal. I would say like mild. And then in the apical 4-chamber RV focused view, the right ventricle is I would say like severely dilated, as it is more than the size of the LV. The right atrium is dilated. There is bowing of the intraatrial septum towards the left side, indicating raised left atrial pressure. The left ventricle contractility appears normal, and the right atrium appears small. And there is also bouncing of the interventricular septum, which again goes in favor of the RV afterload, increasing RV afterload.
Cool. And forget the stuff behind the heart. And you got signs of maybe some atelectasis going on there.
Yeah.
Occasional B-lines. Yeah. Good.
Yes. I think it's the again it's a apical 4-chamber view with a ultrasound enhancing agent, or I'm not sure. It looks like it's like a contrast, not like a agitated saline. And at the same time, there is a shunt from the right atrium towards the right ventricle within 3 cycles that says there's an intracardiac shunt. With my previous non-contrast apical 4-chamber with a bowing septum and the right-sided increased pressure, I expect there could be possibly pattern foramen ovale with a right to left shunt.
I think it's don't get too nervous and just get that terminology right, because I think you talked about there being bubbles going from the right atrium to the right ventricle. I think you said, just make sure you said right atrium to left atrium. Just again, when you get nervous, just take your time, because I think there were just a few slip ups. I think the examiners are going to be totally cool with that, to be honest, because they're going to say, "Excuse me, did you say right atrium to right ventricle? Did you want to, did you mean that or something?" But yeah, very nice. And so, how many cycles would it be for it to be a intracardiac, and how many for an extracardiac shunt?
It's actually ideally it's less than three cycles, and if it is more than 5 cycles, it is extracardiac.
Yeah, I had 5 and 7 in my head, but yeah, small number for the intracardiac shunt, bigger number over 7 for the extracardiac shunt. Very nice. Okay.
The top image is RV focused apical 4-chamber. I can see the RV is severely dilated. There is bouncing of the interventricular septum. The tricuspid valve is opening well, and I think there is some good coaptation as well. The annulus appears slightly thickened, and the right atrium is severely dilated. In this picture, when compared to the previous one, I can see the left atrium also appears dilated. The LV I'm not able to see fully. And then we got the continuous wave Doppler of the tricuspid inflow, where the peak velocity is 2.78, which is almost near the upper limit of normal. And then the PV acceleration time is 57 seconds. It's suggestive of a severe pulmonary hypertension. In the Doppler trace, the heart rate is, to make sure it's reliable, I'm not sure how much is the heart rate here.
The heart rate was 100.
100, yeah. I think 100 is, maybe it's like the reading is, I think I can take this number more, but I prefer this Doppler trace, the sweep rate to be increased to at least 200 per second, and then I'll measure it. And also I can note it here is there's a mid-systolic notch, which is suggestive of precapillary pulmonary hypertension.
Very nice. So again, just remember the pulmonary acceleration time is not so indicative of severe pulmonary hypertension. It's about increased pulmonary vascular resistance. All right. So just make sure you get, again, those things right. Everything you said was perfect. Again, the excellent candidate is going to remember about the previous TR that Umi was talking about. So she talked about how well it was, filled in. She was almost, I think you said it was trivial TR, as opposed to now where we've got much more demarcated and a slightly higher number. But we've got a slightly higher number with a markedly impaired RV function. So again, just put through that pressure difference that you're seeing in this bottom left image in the setting of the RV function. So if you can put that all together, we say that there has been a significant change, I think, in this patient's RV-PA coupling from the first one to the second one. And what we've got here is the start of an uncoupled RV-PA system. Yeah? So remember, it's the simple cheats way of doing it is you do TAPSE in millimeters divided by your peak systolic pulmonary artery pressure, and anything less than 0.4 is uncoupled. And I'm sure this patient would be right on the border of that. So again, just if you're seeing these, if you're looking through a whole bunch of images of a single patient and they have it before and after something happened, don't forget to compare things to the first one and put that into the clinical scenario. Because what do you think is going on? How would this affect your management decisions?
Yeah, I think from the studies which was done before intubation and after the study which was done, the study which is done after intubation with a 3 days interval, I can see there's a significant worsening of the RV hemodynamics. There's a significant RV dysfunction as well with an increasing pulmonary vascular resistance. So my focus on this patient will be to address which has caused acute increase in the RV afterload. Starting from the patient factors, I will look into the how the disease is progressing. And then the second one is what is the heart-lung interaction with the positive pressure ventilation? How much is the settings, and then how is the PEEP, and then I'll be focusing on improving the contractility of the RV using an RV inotrope like a milrinone or levosimendan, and then I'll be, as I told you, like focusing on the IV afterload as well by optimizing the pulmonary vascular resistance, optimal PEEP, and also I will see, is there a possibility of recruiting the lung and improving the atlectasis? Is there a drainable pleural effusion? And then I'll consider, is there after ruling out there is no reversible things I can do here, I'll be considering a pulmonary vasodilator as well.
Don't forget about PE. This is my last bit.
Yeah. Sure.
Okay. Because obviously we got these features here, and there is, I think there's a potential suggestion of a McConnell sign, giving you the flying W sign. We've got a 60-60 sign in all of that. So again, pulmonary pressures less than 60, a pulmonary acceleration time that's less than 60. So that's the 60-60 sign. Maybe a suggestion of a McConnell sign at the top, with that acute deterioration, day 3 being in ICU with shitty lungs. It can be PE, it can be lung parenchyma, it can be us with the PEEP, okay? And mixed in with a bit of fluid congestion potentially. So not bad. I think it would have been a pass, but I think you could have got to a pass well if you just tied in just a couple of other things with the old study and then also just the features that we're seeing on that echo. Okay?
Thanks.
Nice
Sam,
job. Yeah.
Sam, can you just repeat the you were talking about the ratio for ventricular uncoupling? Like, was that TAPSI to?
Yeah, so I do TAPSI in millimeters.
Yep.
So in this case, if it's 50, so instead if it said 1.5 centimeters, I just make it 15 millimeters, and you divide that by your peak systolic pulmonary artery pressure, so SPAP. So this one would be 30 plus 15 of the IVC. I didn't show it to you, but I'm sure it's dilated. And so you call that 45. So doing 15 divided by 45 is 0.3, isn't it? And
Yep.
so that would be, is that right, doing it off the top of my head?
Yep.
So 15 divided by 45, yeah, so it's 0.3. So that's less than they cut off 0.4 or 0.3. So if it's less than that, as in if your pulmonary pressures are going up and your TAPSI is going down, you're becoming more and more and more uncoupled. And that's you heading in the wrong direction. And that's got prognostic implications in the critically ill, particularly those with left-sided heart disease and with pneumonias,
Okay. Thank you.
according to Emma's study. But it's as with all of these things, I don't think it should be taken in isolation. But I'm finding it increasingly useful in this kind of personalized shock management that I'm kind of doing at the moment. Just as a quick number to give you an idea about where they're at, mixed in with all your clinical and other echo features. And then I watch it down the track. And if it's getting lower and lower and lower, we're doing something wrong. Cool. We might leave case 2 for another time because I'm sorry I've got to go and do an afternoon shift. So let's do a real quick overview of echo and respiratory failure. I try and think about it in terms of just work your way around the cardiovascular system. LV, left atrial pressure, lung, water, RV afterload, RV systolic function, and then you match that all in with your management choices. So you can eyeball your LV. Don't forget about some ways it can affect your left atrial pressure, like with MR, because again, with mechanical ventilation, that's going to affect your mitral regurg. I'll look at stroke volume. We'll do all our usual left atrial pressure estimates, in particular EA ratios, plus or minus D cell times, E to E primes, as long as there's no regional wall motion abnormalities, and then pulmonary veins if you can get them. Consider lung ultrasound. I'm just looking for pleural effusions and B lines. Again, B lines can be caused of lots of things, not just raised left atrial pressure or pulmonary edema. It can also come from pneumonitis, aspiration, ARDS. So it's about the patterns and dependent areas more than anterior areas for pulmonary edema. And just again, take it with a pinch of salt. Think about that's all post-capillary. So then pre-capillary, that's going to be your ARDS. It's going to be your hypoxia, hypercarbia, acidosis, pulmonary vasoconstriction. It's going to be microthrombi and big thrombi. And that's the flying W sign, shortened pulmonary acceleration time, and obviously estimations of your systolic pulmonary artery pressure, which is the same for both. People do use ePLAR. I think this doesn't take into account the RV systolic function, which is my one argument for this one, but it's a way of starting to consider the left atrial pressure with your afterload that we're measuring from your RV RA pressure difference there. So ePLAR, they might ask this in the exam, just have an idea that it's another scoring system that comes from Australia. Okay. What I do think you need to know is some idea of this table. Would be another great question of compare and contrast pre-capillary to post-capillary pulmonary hypertension. And I'd expect you to know all of these through there. Easy one to forget is the one that Raj picked up nicely on this one, which was talking about the patent foramen ovale that we see in, not surprisingly, 1 in 4 patients with ARDS, and that can be associated with hypoxia. RV function, eyeball, fractional area change, TAPSI. You can use others, but just have an idea that your longitudinal function does get impaired when you start getting cor pulmonale. Your longitudinal function can be preserved when you've got cor pulmonale. So you've got to use your eyeball, and you've got to think about other measures such as fractional area change and speckle tracking that can kind of estimate what the contractility or that bellows function is of your right ventricle. And the last one that I love adding in is those signs of congestion, hepatic, portal, and renal vein flows. And I think you're all pretty good with this. Forgive me, Patrick, if you're not using this a lot, Vexus. It's incredibly useful. I'm using it more and more in my practice, and it's useful for obviously for signs of congestion and RV failure.
Yeah, I've been using it when I can find the portal vein.
Yeah, nice. Exactly. Yeah, me too. And that's about it, guys. Thank you for listening. Are there any questions on that?